Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we are going to talk about ICD-10 documentation for gynecology. There are some changes you will need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. Let's get started. We'll help you dissect these changes. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and document the organism when known or suspected. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, document acute salpingitis instead of salpingitis, or complete uterine prolapse instead of simply uterine prolapse. Use due to or secondary to indicate cause and effect, and to record all conditions the patient may have, such as infertility due to tubal occlusion. Think about the most current terminology to describe a condition or different aspects of the disease. For example, CIN grade 2 or cervical intraepithelial neoplasia grade 2. Precisely designate anatomical sites such as lower inner quadrant of right female breast. Document the organism you are treating when known or suspected, such as pelvic inflammatory disease due to chlamydia. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care? Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. In ICD-10, there is a feature called Laterality for right, left, and bilateral, which is found in many diagnoses and procedure codes involving paired organs, or those codes specific to one side of the body versus the other. For example, acute left otitis media. ICD-9 has a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes which you have probably heard so much about. Since you usually include this information in your patient care notes, additional documentation will typically not be needed. So for your information, if you happen to omit laterality when needed, it may result in a query. Suffice it to say, laterality is included when appropriate for some conditions you may treat. For example, dermoid cyst of left ovary. Do a quick double check of your notes to be sure you included it before signing off. We'll try not to belabor this point in the upcoming slides. There's not much change in the documentation requirements from ICD-9 to ICD-10 for breast disorders, with a few exceptions. Laterality has been included for some of the breast disorders, as well as for neoplasms of breast tissue. Several signs and symptoms now have their own specific code. As you can see on screen, there are now codes for breast induration, nipple discharge, and nipple retraction. In ICD-9,
these conditions were assigned the generic code of 611.79, Other Disorders of Breast. The increased specificity of the ICD-10 codes for these conditions may assist in supporting the medical necessity of diagnostic evaluation of breast imaging, for example. Under ICD-10, the code for a capsular contracture of a breast implant has been moved from the section of the coding book entitled Other Specified Breast Disorders to the section Mechanical Complication of Breast Prostheses and Implant. Complications of breast implants, including breakdown, displacement, and leakage, along with other mechanical complications, already resided in this section, so it is logical that the capsular contracture was moved to this section in ICD-10. Also new in ICD-10 is code Z45.81, Encounter for Adjustment or Removal of a Breast Implant. Note that this code provides specificity about whether the left or right implant is being adjusted or removed. There was not a specific code for this type of encounter in ICD-9. This code would be assigned when there are no problems or complications with the breast implant. For example, this code would be assigned if a tissue expander was being removed without synchronous insertion of a permanent implant, or if a breast implant was being removed or exchanged for a different size or different implant material. There is one more new code in ICD-10 that I'd like to mention, which is Z42.1, Encounter for Breast Reconstruction Following Mastectomy. This code is used when you are performing a breast reconstruction that is not being done at the time of the initial mastectomy, but rather at a later date. What's new with fistula of the female genital tract in ICD-10 is that more specific codes have now been provided. There are codes for vaginal fistula to either the small or large intestine, as well as other intestinal genital tract fistula. Your documentation will need to include the anatomic location in the intestine of the fistula in order for accurate code assignment. There have been some minimal changes to the codes for hyperplasia of the endometrium and dysplasia of the cervix, vagina, and vulva. The codes for vaginal intraepithelial neoplasia, also known as VAIN, vulvar intraepithelial neoplasia, VIN, and cervical intraepithelial neoplasia, or CIN, have specific codes for dysplasia specified as mild, or grade 1, and moderate, or grade 2. Severe or grade 3 intraepithelial neoplasia is classified to the code for carcinoma of the particular site, such as cervix. Endometrial hyperplasia is coded to either benign or unspecified hyperplasia, whereas endometrial intraepithelial neoplasia, also known as EIN, is coded to a malignancy. Your documentation will need to include the specifics about the dysplasia or hyperplasia, since the coding professional is not allowed to obtain that information directly from a pathology or cytology report. What's new with the code for excessive and frequent menstruation is that it is now specified as associated with a regular menstrual cycle or with an irregular menstrual cycle. The coding professional is dependent on your documentation of the regularity of the menstrual cycle in order to assign one of these two codes. Additionally, it is important to indicate in your documentation whether this bleeding is occurring at puberty, during the perimenopausal period or in the postmenopausal time frame, since there are separate codes for excessive or frequent menstruation at each of these different time frames. There is a new category of codes in ICD-10 that classify complications associated with artificial fertilization. These codes identify infection associated with artificial insemination, hyperstimulation of ovaries, complications associated with the attempted introduction of fertilized ovum following in vitro fertilization, as well as complications associated with the attempted introduction of the embryo during embryo transfer, as well as any other complications that may arise. What remains the same in ICD-10 are the code options for female infertility. Your documentation should identify the etiology of the infertility as being due to either anovulation of tubal or uterine origin or another etiology. In ICD-9, there are codes for hemorrhage and accidental puncture and laceration that occur intraoperatively or postoperatively. ICD-10-CM brings increased specificity for these occurrences. There are separate codes for intraoperative hemorrhage or hematoma, as well as post-procedural hemorrhage or hematoma of a genitourinary organ system or other structure. The codes are further specified as complicating a genitourinary procedure or other type of procedures. It will be important for your documentation to clearly indicate the time frame when the hemorrhage or hematoma occurred. An example of specific documentation might be as follows. Patient underwent successful abdominal hysterectomy and was transferred to the recovery room. In recovery, the patient became tachycardic with increased respirations and the blood pressure dropped. Stat CBC was drawn and revealed decreased hemoglobin. Patient returned to OR and an abdominal incision was opened. The patient was found to have a small arterial bleed, which was identified and sutured. The incision was closed and the patient transferred back to recovery room in stable condition after sustaining postoperative hemorrhage. There is a similar change for accidental puncture and laceration of a genitourinary system organ or structure occurring during a genitourinary system procedure or during another type of procedure. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a malignancy would be metastatic cancer to right lower lobe of lung from left breast. Patient underwent mastectomy 1 year ago, and there is no evidence of recurrence. This documentation clearly identifies the primary and secondary site and states the primary site is no longer present, all of which are factors considered in code assignment. It is perfectly acceptable to state primary site unknown or to state a diagnosis as possible or probable. There's nothing new with blood loss anemia in ICD-10. It is still classified as anemia due to acute or chronic blood loss. There is, however, an opportunity for improvement in documenting this diagnosis. If the anemia is due to blood loss, you need to be certain you indicate the cause and effect in your documentation. We see here in this example of medical record documentation the final diagnoses of a patient who had an outpatient D&C for menorrhagia. The patient had a hemoglobin of 8.5 due to chronic menorrhagia and received a transfusion of packed red blood cells. The current documentation does not indicate the etiology of the anemia. Improved documentation for ICD-10 links the anemia to the chronic blood loss sustained as a result of the irregular uterine bleeding.
What is new with urinary tract infections is that the diagnosis of urosepsis can no longer be coded in ICD-10. In ICD-9, a diagnosis of urosepsis defaulted to the code for an unspecified urinary tract infection. If you record a diagnosis of urosepsis in the ICD-10 environment, it will generate a query asking you for clarification. If by using the term urosepsis, you mean the patient has a UTI, then document UTI. If you mean the patient has septicemia from a urinary source, make sure to document this. For example, E. coli sepsis due to UTI. There's not a lot new with urinary tract infections in ICD-10. If you know the site of the infection, it's important to note it, such as cystitis, urethritis, or pyelonephritis, and if the condition is acute or chronic. If the infection is related to a device, you must document this relationship, such as UTI due to indwelling Foley catheter. Lastly, if you know the organism causing the infection, make sure to document the cause and effect relationship in your note, such as E. coli UTI. Given the health risks of obesity and the number of obese people, it is important for us to be able to continue to track the prevalence and cause of obesity among U.S. adults and children. Since overeating is the #1 cause of obesity, it should come as no surprise that ICD-10 has a new code for nutritional obesity, or obesity due to excess calories. So consider incorporating nutritional obesity into your vocabulary when applicable. It's a few less words than obesity due to excess calories. If your patient has morbid obesity, also document if alveolar hypoventilation is present. ICD-10 has a single combination code for it. As in ICD-9, ICD-10 continues to classify obesity due to other causes, such as due to drugs or endocrine disorders. What's new here is that a diagnosis of depression without further qualification is coded to F32.9 in ICD-10, which is the code for major depressive disorder, single episode, unspecified. In ICD-9, a diagnosis of unqualified depression was assigned a code that simply said depression. If major depression is not your intended diagnosis, consider adding additional details to your documentation when known. It will change the code and better describe what you are treating. For example, major depression could be further specified as single episode or recurrent. In either case, is it mild, moderate, or severe? If severe, it is with or without psychotic features. Is your intended diagnosis something else other than major depression, such as adjustment disorder, for example, grief reaction, with depression and/or anxiety, anxiety-depression, or depressive neuroses? According to published Medicare inpatient hospital data, the code for unspecified depression appears on 1/5 of hospital records
covered by Medicare. We can do a better job identifying patients with major depressive disorders as compared to those with other forms of depression that are less severe and require less resources. As physicians are increasingly held accountable for patient outcomes, a huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient with history of menorrhagia was found to have unimproved hemoglobin level after 1 month of taking prescribed iron. Upon questioning, patient admitted that she stopped taking the iron because it caused stomach pain and constipation. Or patient has age-related dementia and forgot to take her antibiotic as prescribed. Or patient stopped taking her tamoxifen because she cannot afford the medication. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. We'll take a look at a few procedures that would be performed on the GYN service to give you some exposure to ICD-10 PCS codes and associated documentation requirements. ICD-10 PCS has specific definitions for excision and resection. A code for excision is used when only a portion or a part of an organ or body part is taken. For example, a wedge resection of the left ovary. Resection is taking all of a body part. For example, removal of the entire left ovary would constitute a resection. You don't have to use the words excision and resection according to coding definitions. The coder will apply the definitions based on your documentation of what and how much was surgically removed.
It is important to precisely document anatomical site for all procedures, not just excision and resection procedures.
Here you see the table the coder will use to construct the code for a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Note the column on the left labeled body part. The coding professional will need to determine from chart documentation what body part or parts were resected. In this case, the uterus, cervix, and both tubes and ovaries were removed. 4 codes will be assigned. 1 for the removal of the uterus, another for removal of the cervix, and 1 for bilateral ovaries, and the last for bilateral fallopian tubes. The root operation for all of these procedures is resection, which is defined as cutting out or off without replacement all of a body part, which in this case includes resection of the uterus, cervix, tubes, and ovaries. In ICD-10 PCS, separate codes are assigned when distinct body parts are removed, as seen in this case. In addition, looking at the column entitled Approach, the coder will need to discern from the documentation in your operative report what surgical approach you used to accomplish the procedure. In this case, the documentation states it was an abdominal hysterectomy. Therefore, the value for open approach would be selected. The codes for this procedure would be 0UT20ZZ for the removal of both ovaries and 0UT70ZZ for the removal of the tubes. Code 0UT90ZZ would be assigned for the removal of the uterus, and 0UTC0ZZ for removal of the cervix. The coding professional will use this table to build the code for a diagnostic D&C being performed for dysfunctional uterine bleeding. The root operation for this procedure is extraction, which is defined as pulling or stripping out or off all or a portion of a body part by the use of force. You don't need to document the term extraction. The coder will review the operative report and apply the root operation that best describes the procedure or procedures being performed. The body part in this case is endometrium. This procedure was performed vaginally. Therefore, the approach would be via a natural or artificial opening. There are no devices associated with this procedure. Therefore, the value of Z for no device will be selected. For the 7th character qualifier, the qualifier of X for diagnostic will be selected because the D&C is being performed for diagnostic purposes to determine the cause of the patient's dysfunctional uterine bleeding. The final code would be 0UDB7ZX.
ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.